Good morning, good morning.
Good morning.
Good morning. So nice to see so many of you out here today. I'd like to welcome those of you here in the sanctuary as well as those of you who are joining us virtually. I want to remind you now, we'll say this a couple of times, please fill out the pre-program evaluations. There are two ways you can do it. There's a barcode that is present, which you can scan that. If you are like me and physically challenged, you can also do it by hand. But I implore you, I want you to write like your second grade English teacher taught you all how to write. Do not write like some crazy doctor. Okay. Please, these are not pharmacists who are going to try to decipher this. Write like, your English teacher. Make them proud of you. Just out of curiosity, how many people here, just show your hands if you want to, either themselves has a diagnosis of lung cancer, has a family member that has a diagnosis of lung cancer, or has a friend that has lung cancer? Wow. Thank you very much. Wow. That's a lot of folks. I have always wanted to say this, and there's only one audience to whom I can make this statement and actually have the people understand exactly what it is I am saying. So let me say, ladies and gentlemen, stop your smoking. That's going to be one of the biggest things we talk about. You can prevent something, but you can also treat it, but it's easier to try to prevent things. So if you're a cigarette smoker, please, if you can, stop. We all know it's difficult. If you haven't started, don't stop. And if you got some friends, family members, try to encourage them also. But please understand, it's a difficult thing to do to stop smoking. There is an old saying that says you can lead a horse to water, but you can't make him drink. Now, I guess now that Lucas Oil Stadium has been converted into perhaps the world's biggest swimming pool, this means that if the Indianapolis Colts don't do better this season, their worries will not be about drinking the water. I think someone may try to drown them in that big pool. But having said that, if Indianapolis can make Lucas Oil and water mix, surely our combined efforts can either eliminate or significantly decrease both the incidence and the mortality rates from lung cancer, and in particular small cell lung cancer. Hope is possible with early diagnosis, treatment, and support. This goal, however, can only be achieved by ensuring that access to the treatment advancements for small cell lung cancer are available to everyone, not a select few, but to everyone. And we'll hear about that a little bit later on. These topics and others will be discussed later. Today's program is hosted by the Phillip Temple CME Church and its senior pastor, Paris Lester. And Pastor Lester will now welcome us to get things started. Pastor Lester, thank you.
All right.
Good morning. Truly, we thank God for each of you taking time out of your busy schedule to join us here at Phillip Temple, where we're working. Our motto is simply this, that we're growing in faith, but we're grounded in grace. And today we're excited about what we're doing today with the HEAL collaborative effort to talk about small cell lung cancer. I've been sharing with other persons about what we're planning to do at our church this Father's Day weekend. We know that June is about dads, it's about grads, but also we want to talk about the health of our people. And one important thing I've learned is that lung cancer affects so many people, especially in our community. As a part of the CME Church, one of our efforts is a three-pronged thing that we try to do about salvation, education, and liberation. Salvation found in Jesus Christ, education through our colleges, but also educating so that we have the information that we need to combat against cancer and other things in our community. The Bible says that where there is no vision, the people perish. So today we want to bring about a vision of how we can be healthy in our community. It's already been stated, one thing that we can stop doing is smoking. I've heard this adage before, that on every cigarette, there are two ends. There's fire on one end and a fool on the other. And we want to change that. We want to change that so that we can make sure that we are taking care of ourselves, doing what we need to do to make a difference in our community. So I want to thank Hill Collaborative for being here and working with us today. A special thank you also goes to our Representative Gregory Porter for pulling us together. Can we give God praise for him? And we're making a difference in our community. Now, last point about liberation. We recognize that education is very important, that once we know something, we can do better. So I'm thankful and grateful that we're taking this time to liberate our minds, to learn more about this dreaded disease that we can do to help combat it. Again, welcome to Phillip Temple CME Church, where we're growing in faith and we're grounded in grace. God bless you, is my prayer.
Thank you, son. Is that another prayer?
Oh, well, I'm supposed to be praying. Amen. I'm doing a commercial. Let us pray. God, we do thank you and praise you and give you glory and honor for another day. And now, Lord, for this effort today, we ask you, God, to continue to bless us as we gather to learn information. Your word, God, says that we're to study to show ourselves approved. So we thank you, God, for all of those who have knowledge that they will share with us on today. God, let it be nourishment for us. Also, let it, God, empower us and engage us to go out into our communities to let others know about what they can do against small cell lung cancer. This is our prayer, we pray. In the name that's above every name, is the name of your son, Jesus Christ, we pray. Amen.
Amen. Thank you, sir.
Phillip Temple CME Church is hosting this event, but this is also in collaboration with the Heal Collaborative and Amgen, which is lending its support and personnel. If I could just have all the people from Amgen just stand up so we can know how many of you all are out here from the various places. Thank you very much for coming. And you'll be hearing a little bit more from them. Next, let's bring up the Honorable Howard Mosby, who is the former Georgia State Representative and current Corporate Treasurer for the Heal Collaborative. Honorable Mosby.
Good morning. I am just glad to see you all here today. Pastor Lester, thank you for allowing us to come into your house. Today we are here to discuss this issue around small cell lung cancer. Whether you're a patient or a caregiver, a health professional, or simply just an advocate, your knowledge, the experiences that you have are important to this conversation going forward. And we want to make sure that we bring this information to you, to this community, so that you can make better decisions in your life. We want to be a part of this community to help foster hope, to drive change in this fight against lung cancer. We want to thank our partner Amgen for allowing us to have the opportunity to do this. Organizations and companies that are wanting to come into this community to do this kind of work truly are a blessing. This company has shown its heart in being able to say that we are wanting to really do this work, be a part of this, and we are proud that we are able to lock arms with them to do this work. So I just want you all to know that this is important information. You're going to hear from some of the top experts in this field around this disease. And I can tell you right now that it's life-changing. It's going to be life-changing. And you all will walk out here saying, I wish I had known this before now. And so we're proud to be here to give you this information. This is, again, our honor to be here. I'd like to thank, again, you all for being here today, and I will turn this back over to Dr. Tuckson so he can take us down the agenda. Thank you, sir. All right. All right.
And thank you for reminding me. I forgot to introduce who I am, which is really not important in the grand scheme of things. I'm Wayne Tuckson. I'm a colorectal surgeon. I have the pleasure of being the moderator for this session. Again, I remind you, if you could fill out the pre-program evaluations, and for those of you who are watching virtually, please, again, you can fill it out by scanning that barcode that's down there. We'd appreciate that. Teddy Roosevelt said, "Walk softly and carry a big stick and you'll sleep well tonight." Well, Roosevelt only wished that he had a stick as potent as the Honorable Gregory W. Porter. Representative Porter represents the 60,000 plus good people of District 96, and among his committee assignments is the one that's most germane to us here today. He's a member of the Public Health Committee. Representative Porter, please, if you'd grace us a few words.
Good morning to each and every one of you. Good morning. Good
Morning.
Good morning again.
Good morning.
So glad to have you here at Phillip Temple. You've heard from my pastor. And as a body, Phillip Temple family is just very happy to be in collaboration with Gil and Hill Collaborative. You know, being a public servant and being a policymaker, it's important that we bring information back to our community. And as policymakers, we look at statistics and what those statistics really mean to certain initiatives that we have as we build laws, make laws in the state of Indiana and across this country. And health, and particularly public health, is so important to us. And as a member of the Indiana Black Legislative Caucus and also a member of the National Black Caucus State Legislators, we work and focus on health disparities. We understand that if you don't have a good health, you don't have a good life. And if we don't take it seriously, we will continue to create a demisement of our people. And so as we continue this conversation, glad to convene it, to educate, but most of all with the four entities that are here today, collaborate so that we can have good educational outcomes for our people. It is time for us to be selfish when it comes to health care. And if we are not, I'm not anti anybody, but I am pro us, so that we will have good health care and have a good economic base and build a future for our children. And these are the conversations we're going to have today, and we're going to continue with these conversations. So again, thank you all for being here. We're going to stay focused on what we need to do as a community to make sure that we have all the tools in our tool chest. We're going to stay strong, because if we don't stay strong, nobody's going to take care of us but us. And last but not least, with us being here together, we can do anything we can to address health disparities in our community and put the tools in our tool chest to build our society. Thank you, ladies and gentlemen.
Mr. Mosley, I got to put that on record as the shortest time I've heard a politician speak ever. However, listen, you truly is a church today for that. Thank you very much, Representative Porter. Next, we have what we call the fireside chat. This is if you will, imagine we're sitting around a living room, little roaring fires going on. We all have a little cup of coffee, tea, or something like that. And it's just a discussion about what it means to be a patient with lung cancer, or to be that person who's caring for that individual with lung cancer. I'd like to bring up Ms. Ronnie Ford. Ms. Ford is a small cell lung cancer caregiver and is an advocate. And she'll tell you a little more about herself in a moment. Pastor Lester, if you could please come back up and join us. And to moderate this session, and Pastor, there's a glow in this church. Probably always is a bright glow, but it's especially bright today because our moderator, Ms. Cassandra Smith, just got married. And I think she's still basking in that glow. So let me get this. Ms. Smith is the Advocacy Relations, Corporate Affairs, and Amgen of Amgen Corporation. Take it away, Cassandra.
Good morning, everyone. Okay, sorry. Good morning. Thank you. Thank you for the congratulations. And just been invited to Awesome. So back at it. My name is Dr. Jackson said it's Cassandra Smith, and I serve as Amgen's Health Activity Director. And our goal is to ensure that Amgen is working and really building an industry at the pursuit of creating a equitable healthcare system. Funding the lens that we can. can't do all things. You absolutely can do a lot to make sure that we serve patients, all of our patients, equitably. Part of my job is to be here and working community. And this is my passion, this is this is where if I could spend every single day here, I just think that it's important to shape. And Amgen shows up. You know, Amgen really does want to be connected to community and ensure that we're providing information. So we're in for a treat this morning as we, hear from the experts that we have and really learn a little bit more about cancer prevention, importance of screening, and we just have a wonderful program. So I'm joined here today by Pastor Lester. Thank you so much again for having us here today in your home and in front of your family. And we would like to hear a little bit more about why you invited us here. You gave us a little, preview to that, but really why did you invite us here to this year collaborative to be part of this, community and provide this information?
Thank you. One of the main goals of the church is to do ministry outside of the walls as the Bible.
And we're correct.
I think can y'all hear me? Can we pick up? Close.
All right.
So one of the initiatives for our ministry is to reach outside the walls and to share with the community and indeed the world information that's transformative. The gospel, we specialize in reaching persons to save them from their sins, but also we wanted to do something that would be relevant for today. So that's why we wanted to reach out. We again spoke about Brother Greg Porter, who shared with us that this would be a great idea. We're also in the middle of our Men's Day weekend, so we have a lot of stuff going on. So we thought this would be an awesome time. Not only is it Men's Day, not only is it Father's Day, but this is Juneteenth for our people, another part of our freedom. And what a better place to have freedom than in our health. So this would be an awesome, and we know that there's a lot of stuff going on in Indianapolis, but we wanted to pause, take time for us to get more information to learn about what can we do to take care of our bodies. But we recognize that once you're well, you can do anything. But if you're not, so we use this as an opportunity, as they say on the airplane, put your mask on first before you try to help somebody else. So we use this as an opportunity to put our mask on to go out and help others in the community.
Thank you for that. And knowledge is power, right? Yeah. Without knowledge, you can't do a whole lot because you just don't have the speed to be able to make an impact on your own health and have to do things in friends just to get it. So thank you for having us. So I'm gonna now transition over to Ms. Ford. Ms. Ford, we got a chance to know each other when preparing for this. Hey man, you have a really interesting background. And also really important story that I'd like you to share a little bit with our family here. If I could ask you maybe to talk a little bit about your road to becoming an advocate in lung cancer, and then really your community as that.
Well, first of all, let me say hi, family. My former name is Reed, so some of you may know the name Reed from this church. My former in-laws are part of this church, and I still consider myself you all family. They're still my family. And so let me start out with saying my professional role, I work for the United States Senate in the role of Deputy Regional Director and a Minority Outreach Liaison. But prior to that, I worked in public health for 10 years. And having that footprint in public health helped me understand disparities, the need for information, the need for us to address issues. And so with that, when my mother was diagnosed with lung cancer in 2017, I understood a lot more than a typical human being might be able to navigate in that situation. Unfortunately, it didn't make it any easier for that transition and that caregiving to take place. So I'll stop right there and let Ms. Cassandra ask me some questions, but that is a little bit about me.
Thank you so much, and thank you again for being here. So, Dr. Jackson opened us up talking about smoking. We heard about smoking, and smoking is really important. And I think there's another part to this. If you are going to choose to smoke, screening is important. That we also know that screenings don't happen at the same rate in our communities. They don't happen as it should, period. Full stop for everybody, but especially in our community, the Black community. So, Ms. Ford shared a little bit about, your mother having I don't know how many years, but smoking, starting from a really early age, and starting to commence. And yeah, could you talk about that?
Yeah, so my mom was born in 1946, and so we all understand the culture around her teen years. The social norms were smoking was glamorous, smoking was approved. Smoking was even encouraged by some doctors in their targeted marketing, and it was extremely and intentionally targeted to the African American community. I learned this because I worked in public health as a smoking cessation program coordinator around those issues, understanding how those roots were dug into our community. And so my mother smoking at 14 years old led to having a lifetime addiction to nicotine. The really sad part about it is 3 of her siblings did the same thing, and they also succumbed to lung cancer.
So, as your mother started to feel like something isn't right here, screening was not really at the top of the care, right? Could you talk a little bit about that?
Sure. The other thing is, and I don't bash the medical industry, but in terms of the evolution of how our society has aged and what needs to be addressed in those primary care visits and how we need to talk to patients and so forth. Those are some critical things. That's another thing I learned in the public health space, is that the primary care doctor is that front door for patients. And so that conversation you have with them about what's going on in your life, is anything changed? How do you feel? How often do you smoke? Do you smoke? To caution you and coach you on stopping smoking. With my mom, her doctor, I think he did might coach her just a bit, but one of the things is that she had a medical episode, and she had some diagnostic tests done, and there was a spot, but the doctor did not pick up on it. And until she went to a second doctor with symptoms of pain, we all know that lungs don't exhibit pain, but as the cancer grows, it grows to places that cause us pain. And so that's what alerted the doctors about my mother's cancer. And that pain alerted them, but unfortunately, it was too late. And she was diagnosed with only about 6 months to live.
Screening, critical. And we're going to hear in the program later on this morning just how important screening is. Dr. Bernard's comes there, really, give us some information. But I think, the takeaway of your mother's story is that, we have to advocate for ourselves as well. So in this example, your mother was, something is not quite right. Mm-hmm. Nobody really considered her history as a smoker to do anything. And you shared with me that had that happened, because she finally did get screened, but then it was kind of like, well, what do we do with the screening? We did the screening, but then the utilization of that screening is just as important, and that didn't happen, right?
Yeah, that's one of the other things. Although, as I stated, I was a public health professional, there were lots of options given to me and our family for her treatment, but it was very overwhelming. The doctor had said, this is a critical situation, that it's for stage 4 and so forth. So we spent a lot of time running around trying to find out what's the best option, or trying to find different areas where her cancer could be taken care of, which was very, very taxing. which led to my mother having severe depression. My mother had been extremely active. She was active in politics, she would volunteer, she did so many different things. And so her quality of life just gradually just disintegrated. And she was so depressed. And then the pain of the cancer also became overwhelming. And so the treatment and the options, that was a space that really caused us a lot of difficulty.
Well, there's another opening in the room, and I wanted to jump into it. So, treatment and options. So, Amgen being a biopharmaceutical company, we produce, treatments, medications for diseases like lung cancer, and small cell, as well as a myriad of other diseases. Clinical research. Let's get into it. Clinical research, especially in the cancer space, is critical to keep an open mind about. And I wanted to ask, we did not cover. So this is all totally off. We didn't talk about this in our preparation. But I wanted to ask, did your mother, was she ever approached about clinical research? Yeah.
No, she was not. I think because it's the timeline, unfortunately, from the time she was diagnosed to the time she passed away, it was a very short period of time. But it wasn't something that we were aware of as a family. I had one sibling, and to understand those types of things about the clinical research, that's something my sister and I have actually become a part of, to put ourselves in a situation where we can be a part of clinical research studies and so forth. My son, who I'm very proud of, who is a Reed, is a doctor of pharmacy. And so the science behind things is important to me. I understand that. So I understand the importance of us being engaged in those type of situations.
It is critically important. And we all get a headache, we take Tylenol, Matrin, or whatever it is we take. Those all had to be in front of the research. Saying to really, progress treatments, you have to take clinical research, and we all need to be part of it, not just the majority population. So, Pastor Garcia, I'm going to turn it over to you to just ask a question about, cancer research is a hot topic, especially in our community. We have a lot of medical mistrust in our community that stems from historical events, but that's a current social events. And I'm just wondering, the church of this church and a pillar in the community, what can we do to better educate ourselves about clinical research? And this question is for Amgen, but also for the community. What role do you think we have in sharing this message and just making sure people understand what clinical research is and that it's not, and the protections of things? Because I think that's another part of the conversation we sometimes talk about, and we need to make sure people are covered.
Thank you. I think one of the great things that is happening, what we're doing now, being able to have these type of conversations, and to really be honest about it, that's why having other black people tell me. When we feel comfortable that you have some type of connection, because, as you stated earlier, there's always been a sense of mistrust. But we do know that this person that given the information, and if you think about it, as you said, there are many definitely taking place. Many of the great inventions were gained by black scientists to get to where we are today. Even Jesus spits on the ground, takes blood, and puts that man's eyes, and he's able to go on to be blind. So there are instances where we see where clinical trials do what we saw as we came through the pandemic. We have to gain person's trust to go and get vaccinated, now get boosted. So I think the more information we could get, and especially in our community, having more African Americans training to go to our community to just change that and to speak to us in our community.
Thank you for that. Well, that's really important, and I think that really is the importance of having these kinds of community programs. So I'm looking now. Dr. Tyson, if you give me a time shot. Okay. Oh, thank you. I was run over, so I need to. I didn't feel the eye on the side of my head today, but I just wanted to make sure. So I think, as we listen to the program, I will wrap it up, but as we, listen to the program today, I would also encourage everybody. There are experts from Amgen here to talk about clinical research, talk about lung cancer, talk about whatever you want to talk about. We are here. And there are also physicians from your local community that could answer questions about how to get connected to care. Again, any questions that you may have. So please feel free to use us, while we're here. Even if it's not, for you today, if there's somebody in your family, friends, community that could benefit from the information, we are here, private and professional staff members that any one of us, sorry to speak for everybody here, but would be willing to share. So please do use us while we're here. And again, just thank you for your attention today and being fighting, coming out on this beautiful Saturday to be with us. Before we close, I just wanted to turn it over to Ms. Ford and Pastor. Any final words that they'll get to today?
Yes, the first thing I have to say is stop smoking. I think that this is a social norm that our community has adapted, and we need to readdress it in a way that it really needs to be approached. Unfortunately, young African Americans don't pick up cigarettes in their teens, they pick them up in their early 20s. And with this, that becomes a social norm, and then it leads to other critical issues. Secondly, that I am so glad that this information is becoming available. We cannot make our lives better if we do not get the information. And then thirdly, last thing is I am so glad that our faith community is connected, and that we are getting back to our roots as a community, as a Black community, to understand that our faith and our families and our community all go together, that we all have to work together. Thank you.
Yeah, thank you for this opportunity. As you already stated, yes, we want to make sure that we choose better, healthy lifestyles. We know that there's a lot of information now, and you're mentioning about young people. I know there's a big trend now, decaf or e-cigarettes and other things like L1. So there are other things that also that we can kind of educate folks in there. Is this really healthy for get something we could get? So efforts like this, I believe the faith community is also helping people understand faith, understand fitness, how you take care of your whole body. We believe that things in the church, tithing, time by time, talent, training, local attention. I didn't take care of our attention so that we could be more useful to God, a useful idea.
At the DJ, I'm going to
That's the thing.
yes. Okay. Well, thank you all again for your attention today. We're looking at Dr. Hudson.
Thank you very much, Ms. O'Neill. That was very great. How many people have heard of screening for lung cancer? Just raise your hand. How many people have heard of it?
You can speak.
Good. Our first speaker is Dr. Eric Flanow. Dr. Flanow is an associate professor in the Department of Medicine at the Morehouse School of Medicine in Atlanta. He's also the chief and director of pulmonary and critical care and interventional pulmonary medicine, as well as director of the lung cancer screening program and lung nodule clinic at the Grady Hospital Morehouse School of Medicine. In recognition for his stellar work during the COVID crisis, he was named by his peers as the outstanding physician in Atlanta. And for this, he was the cover photo for that month's issue of Atlanta magazine. Yes, we have a cover boy with us. Dr. Flanow will discuss disparities, prevalence, screening, diagnosis, risk factors, and staging of lung cancer, as well as differentiate non-small cell lung cancer from small cell lung cancer. Before he comes up, I will remind everyone that if you hear or think of a question, something that gets in your mind, at the end of our speakers, we're going to have a panel, And we're going to take those questions then. Also the same thing for those of you who are watching virtually. Please send in your questions and we'll get to them when we have our panel at the end of each of our speakers. Dr. Flannel.
Yeah.
Good son. That's a lot to go over in a short period of time, so thank you for kind of keeping it on time because I'm going to run over.
He's really tall.
But here's what I need to do. I need to explain to you exactly what lung cancer is. Can we get the slides started?
My former husband, 6'7".
What exactly lung cancer is, how it impacts our community, and how it goes through and plays a role in what we need to get out to the message we need to get out to others so that they're educated. Because there's one thing I do believe about health disparities and decreasing these health disparities, and you can't do it without having knowledge of what these health disparities are. And without health education, you don't get health equity. Next slide. So what exactly is lung cancer? Okay, next slide. So you don't catch lung cancer. You don't catch it. Somebody doesn't give it to you. It's not something that's just kind of just pops out. Well, sometimes pops out of nowhere, but usually there's a trigger to it or whatever else. But let me explain exactly what it is. So right here, you can see this little cell here. That's a normal cell. It could be a breast cell. It could be uterine. It could be prostate. For this talk, it just happens to be lung cancer or lung. But what happens is something happens, there's a genetic mutation, and this cell becomes abnormal. And the abnormal part about it is it just grows out of control. And it divides and divides and gets bigger, and it starts taking over other parts of the body. And that's what cancer is. Okay? So when you understand that, then you start to say, okay, now there's a basis for this. Next slide. Okay. So when we think about lung cancer, there's two types, right, that we like to break the categories. Now you got to give us doctors a little bit of a break here. We're not very good at naming things, okay? So there is a type where the cells are really small, right, and they grow very fast and they spread. So each one of these purple dots, that's the cell, and that's called small cell lung cancer. These grow very fast, they spread very fast. There's a high relationship to smoking with small cell cancer. So that's why we'll talk a little bit about this, okay? And we just kind of divide it on, we'll talk about this later, on how we stage it. It's either, like one spot or it's very extensive. And then there's non-small cell, right? So we didn't come up with it, but you can see the cells are a lot bigger. Okay, these are larger, they grow a little bit slower. There's more causes related to it. Smoking still comes into play with it. And then we stage it in whether it's in one spot or regional in the lungs or if it's spread all over the body. Next slide. Okay. So we think about these causes of lung cancer. We know, and you all know, that about 95% of lung cancers are related to smoking. Okay. There's a number 2 cause. It's radon. How many have heard of radon? Okay, so if you haven't heard about it, what radon is, it's a breakdown product of uranium, and it comes out of the soil. It doesn't have a color, it doesn't have a smell, it doesn't have a taste, but it's radioactive, and it's related to lung cancer. It's the number 2 cause in the United States. It's such, especially in Georgia where we are, it's such a known cause of this that if you're buying a house, you have to test your house for radon. Right? There's a little test rate. So here in Indiana, of the tests that are done for radon in the communities, 40% of them are above the EPA's recommended levels for safety. 40% of the tests that are done here. So that's the number 2 cause here. That's higher than Georgia. Georgia's only about 30%. So there's something to tell you. So where do you think these houses are located? What communities? Okay, so we have to think about the other causes. So along with that, you have asbestos or pollution. Okay, and asbestos, you'll hear about asbestos if you're up late night watching TV and they start talking about mesothelioma. And say, we know that if you've had asbestos, which was it's an insulation fiber, it gets in the lungs, and it can cause either the lining of your chest to get cancer, which is mesothelioma, or what we don't really realize is if you've been exposed to asbestos, you're more likely to get lung cancer than the mesothelioma. Okay, and then there's chemical factories, and then there's just the ability to have lungs. Because if If only about 95% of these are related to smoking, there's other causes. So just having lungs does put you at a risk for lung cancer, especially if you have a strong family history of people who have never smoked, but they have lung cancer, like in the African American population. Then you can find that that just having lungs is. The thing about this to keep in mind is it's not additive if you have more than one of these, it's multiplicative, right? So if I smoke, it's about a 10% or 10 times increased risk of developing lung cancer. If I smoke and I was around asbestos, which is about 6 times, it goes up to about 60 times the chance of having lung cancer. So when it comes time to talking with your primary care doctors, giving them all the information to find your risk factors is extremely helpful. Next slide. Okay. So why is it specifically bad for our population? Next slide. Okay. So I talked about, we need to think about these healthcare disparities, these differences between races and socioeconomic classes, especially as it relates to lung cancer. And I did this paper a long time ago, and I was thinking about it in 2 different ways, okay? When we break down these disparities and what causes them, you have to think about it as the health. And we talk about somebody's health, it's our environmental factors, what we're exposed to, where we live, if we're smoking, we're not smoking, and our biology. Because I'm going to show you in a few minutes here that there's a difference in the biology, that African Americans are more susceptible to the bad effects of tobacco smoke than other races. You can smoke equal amounts, but we have a higher rate of lung cancer. So there's that component of health. The other component is health care. What's available and what do we seek out for health care? Are we getting the early detection? Is it even available? Are there systemic factors within our health care facilities? Do we have opportunities for screening? Do we have opportunities for diagnosis? Do we have the availability of clinical research studies which can give us the opportunity to get new treatments earlier and have a better chance of survival? Next slide. Okay. So what we do know for blacks in America, when we start talking about differences with lung cancer, we have the highest death rates despite smoking equal amounts as other races. We are less likely to receive screening, less likely or more likely to have it diagnosed at a late stage than at an early stage, less likely to get any treatment at all once diagnosed. Next slide. Okay. So I'm going to show you this. The numbers are really small, but I'll go through the important parts of this so you see. So this is looking at the predicted. On the upper row, we're looking at the predicted number of new cases of all types of cancers for African Americans, men and women. And then we're going to look at the estimated deaths that are going to occur this year, men and women, from the different types of lung cancer. So if we look at the predicted types, you're going to see that for men, number 1, we expect to see about 41,000 prostate cancers this year. Okay? And number 1 for women, about 36,000 cases of breast cancer. Number 2 is lung in terms of new cases. But if you look at it, it's only a third for each of those. Right? So 3 times as much prostate cancer, 3 times as much breast cancer in African Americans. But look what's happening. When we look at the predicted deaths, lung cancer is going to overtake. You're going to overtake prostate despite having 3 times as much. And for breast cancer, breast is still number 1, but we're talking maybe 400, 500 difference in numbers. So it's pretty equal. So even though there's 3 times as much, lung cancer is equal. So it's killing more in the African American population. Next slide. Okay. And so this is what I was talking about. So what we're going to look at in the green here, these are the incidence rates per 100,000 people, how many lung cancers we're expecting to see. Okay. And then we're going to compare this to the smoking prevalence, the percentages of smokers for African Americans, for whites, and for Native Americans. And this is African Americans, whites, and Native Americans. So you can see African Americans about 74, almost 75 per 100,000 new cases, 64, so significant difference, right? 10% difference there, right? And for Native Americans, it's 44. But now let's compare this to the amount of smoking that's done. If we look at men, women, Okay, you can see it's almost equal, 25 to 23 for men and 18 versus 20 for women. So you can see the differences here. Even though the smoking is about the same, the rates of developing lung cancer are higher. And if you really want to see the difference here, look at Native American men. They're smoking almost twice as much, but there's significantly less lung cancer. So what does this tell us? This tells us this is not all just tobacco. There's something that we are more susceptible to the bad effects of lung cancer, or this tobacco smoking. Okay, and we see it with all the other diseases too. Heart disease, other lung disease, strokes. Smoking is bad in our population. Next slide. Okay, so these are the smoking rates, and this is comparing the states that enter data. So if you're over here, you're good in terms of your smoking rates. This is the average in the US. And if you're over here, you're not doing too good. Y'all can smoke down here. I have seen, and we were driving through the neighborhoods, I saw the hookah stores. I saw the tobacco and cigars and cigarette stores from that standpoint. So this is a factor, and so this is going to hit home for Indiana. Next slide. Slides out of order, but yeah, there we go. Thank you. So what I've learned through all these years is not only when I have to ask, do you smoke and how long have you smoked, what else do I need to ask? What do you smoke? Right? Because it does make a difference, because there's some things that we don't know about what you're smoking that do play a role with this. So I'll go through. Next slide. Okay. So here's the thing, and you heard about this. You heard about this a little bit earlier, about nicotine and the addiction part of it, right? If nicotine, that's the addictive part. The nicotine inside of a cigarette is the addictive part. Now, all the other chemicals that are released, the formaldehydes, the benzenes that are released from the tobacco smoke, those are what's going to lead into developing the cancer, about 6,000 of them when you smoke. But the nicotine is what keeps driving you back, that addiction part, to keep smoking, despite all of these bad effects. Okay? If nicotine were a new drug coming out today, the FDA would have a problem with it. Because the only two things that are probably more addicted to it are cocaine and heroin. That's how addictive it is. Okay? So it's regulated in cigarettes. One cigarette has about 8 milligrams of nicotine in it. Okay? So I asked somebody, okay, so they tell me, I had a patient come in and tell me, oh, I cut down, doc, I cut down. I'm only smoking about 2 or 3 a day now. 2 or 3 what? Black and Milds, the small cigars. Okay? 100 milligrams. That's the equivalent of 12 cigarettes. So I said, you really haven't cut down, right? You're getting about 12.5 cigarettes. And then, it's nice because, especially here where the cigar bars are legal down here and people like to go out and they smoke the cigars and whatever else, 200 milligrams. That's 25 cigarettes, right? And so if you think about the component, okay, yeah, he's doing it every once, you're getting a good dose of that nicotine, which is building in and builds towards that addiction. Next slide. Oh, go back one. So we talk about advertisement. The menthol cigarettes, I'm not going to get into that. That's a long debate, which I have a lot of strong feelings about, right? The menthol aid, but it was targeted for African-American populations. We can talk about, how kids were being targeted with the flavored vapes, right? Could get them addicted to the nicotine and keep them coming back, right? You want to think about targeting and targeting with advertising for specific populations? Think about Black and Milds, and why are they called Black and Milds? Now, next slide. Okay, so the new thing now is the hookah bars, right? I don't get it. They come in, they bring this big thing, it's filled with all these chemicals and nicotine in there, and they sit around and they pass this around. They pay for an hour session. You got 5 people just smoking and passing this thing in people's mouths and stuff. There's smoke everywhere and stuff like that. 1 hour session, person gets about 200 puffs, which is about 100 cigarettes. That's 5 packs. And you got to think about it. This is being done as socially acceptable for people who are in their early, their teens, their early 20s and stuff like that. And so that is when the brain is still developing and still triggering and getting stimulated by the addictive properties of nicotine. Next slide. I have a lot of feelings about this, but there's a whole thing, this whole push to legalize marijuana. And what we didn't know, and I used to have patients come and say, I only smoke marijuana, especially from the islands. I only smoke marijuana, and it doesn't cause cancer and stuff like that. Well, it's because we didn't have a lot of information now. Now there's strong studies showing that there is a risk of developing lung cancer if you smoke marijuana. And if you are a heavy user in the study, you get a 2-fold increased risk of developing lung cancer in your lifetime. And so what's a heavy user? 50 times in a lifetime. Yeah, I know, you guys, there's some people who can't get, they'll get 50 times in a week, right? And it just depends on how fat you're rolling it and how it's being, what paper it's in. There's no filters in it. So there is a link. So when we start thinking about what's socially acceptable, especially in our community, in our households and stuff like that, we allow some of these things to develop into some of the risk factors for developing lung cancer that we don't realize. Next slide. Okay. So the only way we get ahead of this, the only way we can get ahead of lung cancer is to catch it early before it starts causing disease. Okay? And that's where screening is. Next slide. Because what screening is, we're trying to find lung cancer before it starts causing problems, before that person has a cough that won't go away, before they're coughing up blood, before they find themselves short of breath that they start significantly decreasing what they can do within a day time, before the weight loss starts developing. That's when we want to catch lung cancer. Because by the time you have these symptoms, about 3/4 of these patients that have symptoms like this, they're already late stage. It's too late to be treated. So screening is important because we want to catch it before we get to some of these symptoms. Next slide. Okay. So the goal of screening is to find this little lung cancer that's developing there before it's gotten larger. So you heard about this early, and just let me explain to you why the screening is important. So the lung doesn't have much. You're going to get the anatomy course here. So these are the lungs here, these gray things. The lung doesn't, inside the middle of the lung, there's not very many nerve fibers there. So there's no sensation. So what happens is this cancer can grow undetected. It's not until it runs across the edge of the lung. If somebody ever breaks a rib, they're in excruciating pain. Well, if the cancer starts growing there, they get in the same pain too. So it has to get large enough to hit the edge of the lung for you to have pain, or to get to the airways where you start having this cough that won't go away, or large enough to where you can't feel that you're getting any air because it's taking over most of the lung. So that's why we want to catch it here, because when you can catch it here, it's the best time to try to get it treated. And that we know if we screen with a CAT scan over a chest x-ray, then you're less likely to die. You have a 20% chance less likelihood of dying of lung cancer if we can catch it. And we know that just by going through the screening together, you have a 25% chance of not dying of lung cancer if you're a person who is at risk for developing lung cancer. Next slide. Okay, so who should be screened? This is the thing that should be important, because if you fall into this category, or you know somebody that falls into this category, then you need to go out and talk with them and encourage them to get screening. Now, a lot of people pull back because they're a little bit ashamed, right? Because the social acceptance of tobacco use has kind of gone down now, and people start feeling a little bit more ashamed. But you need to, we're not going to blame you. We're not going to shame you. We just want to get you screened because we know it'll save lives. So if somebody's between the age of 50 to 80 years old, it used to be 55, but they dropped it. They dropped that criteria. And the reason they lowered that criteria is because we were missing patients who were at risk, and they were African Americans, that we get it earlier. Right? I used to have patients 29 years old, 34 years old with stage 4 lung cancer. They wouldn't have had an opportunity to get screened. So we will probably see this change more as more people get into the screening process. But right now, if you're between the ages of 50 to 80 years old, and you currently smoke or have smoked sometimes within the last 15 years, you're in the range there. The other thing is this 20-pack year use history. Okay, so tell you how we figure this. If you smoke 1 pack a day for 20 years, that's a 20-pack year history. Smoke 2 packs a day for 10 years, 20 packs. So if you're 20 or above in the pack year use, then you're a candidate to get screened, to try to catch it early. That's why it's important to know about all those other things. The small cigars, right, which are 12 cigarettes, half a pack, okay, or the big cigars, or the hookah bars. That's why it's important to know about these things. Next slide. So in terms of screening, actually Indiana is doing good and compared to the rest of the nation, right? Because of all the high-risk people that would qualify for screening, you're screening about 5.1% of those patients are getting screened. That means 95% of the patients who are at a high risk for developing lung cancer are not getting screened, right? So we can do better just by getting this knowledge out. Next slide. Okay. So the difference is, does finding it early make a difference and improve survival? Next slide. It does. So we're looking at a comparison here. Whites are in blue, blacks are in red. And this is when the person was diagnosed with lung cancer. Was it at an early stage? Was this in one spot? Was it at a mid-range stage or a regional stage where it might be in one spot and some lymph nodes? Or had it spread throughout the rest of the body where it's late stage and you're not going to have a good chance of getting it cured and surviving, okay? And so if you compare whites to blacks, we're less likely to have it found at an early stage. Middle stage is about equal, more likely to have it found when it's late stage, maybe too late to get cured. Next slide. Okay. And this is specifically for Indiana, if we look at this. So finding it early, if we take a look at whites versus blacks, finding it early in Indiana, blacks are less likely to be diagnosed early. Surgical treatment, which would be the best treatment to get it completely out of the body and cured, less likely to get curative surgery. The more likely to have no treatment or less likely to have any treatment. So more likely to not have any treatment at all. Okay? And surviving at 5 years, well, we're less likely to be alive if all of these things are playing a role. Next slide. Okay. So let's go back. I know that's a lot of information. So understanding this whole thing about lung cancer, I have to give you when we hear your doctors talk about timing, you get a diagnosis, we got to get through the timing to get things moving and get things treated. There's what we call a doubling time, okay? And if you can follow me on this, you're going to understand more than a lot of the medical students we teach. Okay, so when I talked about this one little cancer going from 1 cell to 2 cells, and then 2 cells to 4 cells, that is what we call a doubling time, okay? So let me put it to you like this. If my cancer is about the same as a teaspoon size, okay? So by time, that doubling time from it to go 1 teaspoon to 2 teaspoons is what we call the doubling time. And then 2 teaspoons to 4, and then 4 to 8. Next slide. So for non-small cell, right, the one that's a little bit slower, we know that this doubling time, by the time I'll have twice as much cancer, is somewhere between 60 to 90 days, right? About 2 to 3 months, okay? Next slide. And so if you can catch it early and it's localized and you move on getting it staged and get diagnosed and staged in the treatment, the best treatment is surgery. Don't delay on getting the surgery to get it treated, right? Once you get that diagnosis, we're moving forward very quickly, okay? And that's for non-small. Next slide. Here's the thing about the surgery. If we're looking, and I'm glad we're getting close to Father's Day, and this is Men's Month here, because here's the thing. If we take a look at white men versus black men versus white women and black women, and we look at even if you have that early stage cancer, how often are you getting the surgery that would get you cured? This is our target population, because everybody else is in the 90% of getting it, and something about our African American men of getting there and getting to the surgery and getting it cured is important. And thing to remember that this whole myth about, if they cut on me or if it gets exposed to air, it's going to spread and it's going to make it worse is a myth. Because if that were the case, it would be bad from the start because there's a whole lot of air in the lungs. Next slide. Okay. So let's talk about small cell, because remember I said this is the most aggressive one. The cells are smaller, they spread faster, right? So this time, but from doubling time is 30 days, 1 month. So if you get this diagnosis and then you sit around and you're going to mope about it, okay, I'll go to this appointment, this is going to be late here and whatever else, and the month goes by, now you have what, 1 teaspoon size is now 2 teaspoons. And if it delays anymore, now it's 4. And this one will spread fast. So that's why it's important to get treatment sooner than later when you have this diagnosis. Next slide. Okay. Because this is the most aggressive. Only about 5 to 10% of the people that are diagnosed with small cell are still alive 5 years later. Right. Extensive stage, if you're diagnosed at a time where it's already extensive, your lifespan is going to be between 6 to 12 months. Okay. And only 10%, even with treatment, only 10% of the patients are still alive in 2 years. Okay. Next slide. Okay. Right, and they divide it up, and you hear about this, about how it's divided into stages of limited or extensive stage. The primary treatment for this, because it's so aggressive, is usually not surgery. Okay, so it's usually chemotherapy and radiation as a combination, depending on the stage and where it's located. There is hope, though. There's new treatments available. One is sort of tarlatamab. You'll hear about this. And these are things where they try to boost your immune system to help fight the cancer. Okay. Next slide. And there's clinical trials going on some of these new treatments. Now, you hear a lot, and we hear a lot about clinical trials in African Americans. And yes, there's some bad history. When I'm not supposed to say Tuskegee, right? Yeah. So not Tuskegee. I'll let him clarify that for you. Right. But what came out of some of those bad episodes in the past is a lot of regulation. A lot of regulation so that we are not to be deemed or appear that we're being experimented on or that we're guinea pigs or something like that. Now clinical trials are tested for safety. A lot of times, especially in these type of trials, you're more likely to either receive the normal standard treatment or the new treatment. So the benefits, especially for African Americans, to be a part of clinical trials is you're more likely to get the new treatments. At the least, you're going to get the standard treatment. So it's better than getting no treatment at all. But the other important part about it is we start to see how some of these treatments, how some of these therapies impact us so that the decisions can be made so that we get equal treatment. So it tells us about African Americans. The problem is that if we look at how African Americans are represented in clinical trials for oncology, we're underrepresented. So a lot of the decisions from the information that come from these trials don't represent us because only 6% of us are involved in them. Next slide. Okay. So a few take-home points here. I know it's a lot. Okay. Next slide. But I can't go anywhere without talking about prevention. Okay. Because about 11% of students in high school here are using some sort of tobacco product, but it starts in middle schools. If we look nationwide here, this is a study they looked at. These are middle school students using any type of tobacco product. It's about 5% across the board. What used to be boys were the problem in the past, now it's girls are using more than boys, okay? And you start getting into electronic cigarettes. Some of the laws have sort of started to curve this, but it hasn't reached zero because if they're starting in middle school, they're less likely to stop. It actually goes up. And here's the big thing, especially in our communities. We can't expect to tell our kids not to do something, what? If we're doing it, if they see us do it. You can tell them all you want. They see you doing it. So that's fine. Next slide. Remember, if you know somebody that would qualify, don't shame. If you are somebody that would qualify, don't blame yourself. Let's just get screened because it does make a difference. Next slide. Okay. And remember clinical trials, right? New treatments are available. It gives opportunity for us to understand how these treatments will impact our population and make a change. and it does give you opportunity to receive some sort of treatment and care that could potentially extend your life. And with that, I should be done. Thank you.
Thank you, man. I did not mean to traumatize you about the comment about Tuskegee. And the reason why I think it's very important that we get it right, if you talk to the surviving family members of the individuals who were in that ill-advised trial, and even talk to Dr. Larry Sanders, he'll also let us know. But it is the full name, I think, because you have to know who it was that did this study. And it's the United States Public Health Service Untreated Syphilis Study at Tuskegee. So it's not that there's something inherently wrong with the individuals in Tuskegee or that they had some misguided. This was something perpetrated upon them. It wasn't a lack of information on the part of them. This was done by the United States government. So we have to be very clear about that. And that's the only reason why. Thank you. So, didn't mean to scare you, traumatize. Pastor Porter, if you don't mind, we have a distinguished guest, and Dr. Shields, if you don't mind, I'm going to just bump you back just a minute. We have with us today Dr. Virginia Kane, and I know you all are very familiar with Dr. Kane. She is, of course, the director of Marion County Public Health Department. She's an associate professor in medicine as an infectious disease person at the Indiana University School of Medicine. She's past president of the American Public Health Association, and the thing I am personally most proud of is that she is the president-elect of the National Medical Association, which is the largest group of African-American physicians in the country. So I'd like Dr. Kane, if you don't mind, coming up and giving us a few words on a topic you have no idea about, I know, how this stuff goes. Thank you, Dr. Kane. Thank you, Dr. Kane.
Thank you, Dr. Hudson. Dr. Friendo, oh, you're going to mic me? Okay, okay. Wow. Oh, you know what? Okay. Oh, okay, gotcha. Okay. I want to thank you. Currently, I'm also the chair for the Indiana University Simon Cancer Center Advisory Committee. So this has been a major critical issue when we look at our cancers in the state of Indiana. And while Indiana looks great from a smoking rate overall with Indiana, if you look in Marion County in our large metropolitan area, our overall smoking rate is 16%. So we have a lot of work to do. And although you will look at our data, we seem to have the same high smoking rates for our black males and our black females compared to what you see on the national level, as we saw on his slides. The problem is that the majority, as he mentioned, of blacks use the menthol cigarettes. And you know, we were really pushing to try to have FDA ban the menthol cigarettes, primarily because it's such a cooling effect. So you know, when you talk about your first symptoms for lung cancer, that's coughing, okay, or shortness of breath. Those who smoke those menthol cigarettes, it suppresses the coughing. It suppresses, you don't realize you're experiencing shortness of breath, so you don't know about your symptoms early to know that, wow, I got to get this checked out for the menthol, besides the fact that it's addicting. And because of the flavor, and it's so addicting, the younger generation loves menthol cigarettes. And you know how that cool sensation when you turn on the cold water and you get that cool sensation? Well, believe it or not, it has the same, attacks the same cold receptor in your lungs, so you got this cooling sensation. It's just mind-boggling, but it is extremely, extremely addictive. Now, here's the piece that I think a lot of us don't recognize in this community. We need precision medicine. We need precision medicine. What do I mean by precision medicine? I'll give you the example of just the breast cancer because people understand that a little bit better. Do you know that the incidence of breast cancer for white females and black females exactly the same? But the death rate for breast cancer is almost twice as much as their white counterpart. But black females have something called a triple threat cancer. Triple threat means that because of genetic mutations or whatever, the cancers that they get, they have a higher predilection of getting a cancer that's more invasive, more severe, at a higher percentage than their white counterparts. And so it moves a lot. He was talking about that doubling of the sales for lung cancer. It's the same that we see with breast cancer. So I say this to say we really need to participate in clinical trials. We need to know that one treatment doesn't fit all. Okay? Sir, I'm sure did you have parents? Yes. Okay, all right. And I suspect when you look at the genetic makeup of your parents, you know you're 20% of your parents and you can't disown them, all right? So it's so important to know that if I'm testing these drugs and it is more effective against this particular invasive cancer, I don't want the general cancer treatment where my efficacy is going to be so low, my cure rate is so low, because I'm just getting the general treatment that everybody gets. I need to get the treatment that's specifically against that particular cancer that I have from a mutational genetic profile. Give me that drug. But until we're participating in these clinical trials, we don't benefit from that. And I say that, I have a mother with breast cancer, I have a sister, breast cancer, and I have a father with prostate cancer. Fortunately, thank God they did not smoke. So we need advocacy, but more important than that, you know, we're supposed to screen for lung cancer. If you've been a smoker, did you talk about the screening? 50 to 80 years of age, right? If you've been a smoker, everybody should be getting a low CT scan every year. We've got to push that campaign. I'm asking the church here now. We've got to push this campaign for past smokers or current smokers that's got a 20-pack year cigarette history. You need to get that low CT scan every year. Cost is anywhere from $90 to $410, so it's not cost prohibitive. But I can tell you, because I've been with a lot of patients such as yourself, we take a long time to have to make a decision because we don't trust as much. We take too long to make a decision, okay? But we've got to move faster, and we have to be knowledgeable. You have to read about your condition. You just can't let the doctor tell you everything and you do no reading of your own, because it makes a difference with them. If they know you care enough about yourself that you're going to read up about your condition, they will do a lot better in terms of really helping to motivate you and get the treatment that you need. Men, you're a little bit slower than your lady counterparts. I'm just telling you, okay? You're a little bit slower than your female counterparts, okay? So ladies, you know what you got to do, okay, if you have a significant other and need some help, you know. This is the one I got this chest pain and oh my God, crushing pain and whatever. Baby, I'm just going to go home and just lie down for a couple of hours, and then if I feel bad, then I'll go tomorrow. Well, of course, she's going to die in the middle of the night because she's not going to make it. All right, okay. So there's a lot we can do for our community, and I just want to thank this church for bringing this incredible speaker. I got to figure out how to steal your slides and whatever, but just an incredible speaker. And we're going to make sure the next time we bring you back to the city, hey, this is going to be packed. We need a town hall meeting about this, Greg. We need to work on this to get a town hall meeting. But thank everyone so much for letting me have this opportunity. I appreciate it.
Thank you very much, Dr. Kane, and I think you reflect the passion of the National Medical Association and all that's about trying to keep black folks alive. Our next speaker is Dr. Misty Shields. Dr. Shields received her MD degree from the University of Texas Health in Houston McGovern Medical School. She completed residency in internal medicine at Vanderbilt University Medical Center in Nashville, Tennessee, followed by a fellowship in oncology at the University of South Florida Moffitt Cancer Center in Tampa, Florida. She also did a postdoctoral fellowship and PhD at the University of Texas Southwestern Medical Center in Dallas, Texas. She is currently an assistant professor of clinical medicine in the Department of Medicine, Division of Hematology and Oncology at the Indiana University School of Medicine, and is a thoracic medical oncologist at the Indiana University Simon Comprehensive Cancer Center. Perhaps most importantly, Dr. Shields puts her lungs where her mouth is, and that she recently climbed the 47 flights of stairs at the Salesforce Tower as a participant in the American Lung Association Fight for Air Climb. I got to give it up for that. Yes, yes. If Dr. Shields can do it, the rest of us can do it. Dr. Shields will speak to us on treatment advances in small cell lung cancer and cancer trials. As she's coming up, how many of you think that lung cancer can be cured? Raise your hands, please. How many think it can be cured? 2 people. You got your work cut out for you. Okay. You go right ahead, ma'am.
It's bright green. Can you all hear me? Yeah. Well, thank you. Thank you to Phillip Temple. Thank you to Pastor Lester and the HEAL Collaborative and Amgen for the opportunity to speak today on small cell lung cancer, which is near and dear to my heart. And I hope that you have something that you can take away, and either for yourself, your family, your friends. There's a wonderful initiative out there. I think it's American Cancer Society that says, "I love you, get screened." Right? I think that's a wonderful message for all of us. We're doing all this in kindness, hope and love, and sharing the good news with everyone, right? And so that can also be our temple of our body and how we can honor God. So if we could grab the slides for me. Okay, hopefully they won't be too shifted. Next slide for me, please. So I wanted to start with this to tell my personal story about small cells. So small cell lung cancer is personal to me. My dad was diagnosed whenever I was 13 years old. He was 48 years old. He was a strong Marine, served his country, was a father of 5 kids, and was diagnosed with a double pneumonia and was ultimately found to have small cell lung cancer at the VA hospital in Dallas. At that time, he was given 6 weeks to live to get his affairs in order. But being a strong father and Marine, he fought for his family, got treatment, and lived 18 months doing clinical trials, doing treatments, and passed in 2000 when I was 15 and he was 50 years old. Next slide, please. I'm the little one there, if you guys don't know. I'm the baby of 5. And so, thank you. And so it was there in the hospitals of the VA in Dallas that God placed on my heart, this is what I'm meant to do for the rest of my life, to never stop fighting for those, to be a voice, to help end stigma, to help give support, to help raise awareness, and to help to never stop fighting for patients who have lung cancer, and specifically in small cell lung cancer. And so we have to end this awful disease, and we can do that by starting screening, by spreading awareness, doing clinical trials, getting research, getting second opinions, and being our best advocate for ourselves and our family. Next slide. As mentioned, lung cancer is silent until it's much later and patients are symptomatic. That's why I wear a white ribbon. That's why lung cancer awareness is a white ribbon. It's actually a clear ribbon because it's silent. It's a silent disease. And so we have to have that knowledge and be armed and doing those lung cancer screenings, stopping smoking, doing everything we can to try to prevent this and catch it early if it does occur. So with small cell lung cancer, what we know is it comes very quickly. You may have a normal scan 6 months ago, you may not have any symptoms, and then you may have a lot of symptoms very quickly. And so it may come out of nowhere, right? That doubling time that was talked about. And so what we know about small cell is it comes very quickly, but treatments are effective. We can get it to shrink, and it can shrink from a very large mass to a very, a dime-sized cancer, or may go away and have a complete response. But this cancer is smart, and it changes, and it adapts, and it mutates, and that's where we have a hard handle on this disease, and that's where it's so important to be proactive and to participate in clinical trials, to do everything we can in terms of prevention. Quitting smoking helps reduce the risk of a second lung cancer if you're diagnosed with small cell at 2 years. And so when it comes back, that resistance to therapy, the things that were working stopped working, the things that we have in our toolbox are just not effective. And so that's where all the trials and all the treatments need to be really focused on. And so next slide, please. So from the 80s, the treatment of small cell lung cancer was really multiple regimens. It was a very toxic regimen called CAV, which was a combination of 3 very strong chemotherapies, and it was the best we had until about the mid-80s, when the combination of 2 drugs, platinum, which is either carboplatin or cisplatin, and a drug, etoposide, became really the backbone. It outperformed. It was better toxicity profile. Patients were able to do better on that therapy and need less things like medications like fluids or having complications and side effects. And so that became the backbone from the mid-80s for the treatment of small cell lung cancer, and every treatment they came up against it failed. It was negative trial after negative trial, and it was such a difficult disease to try to figure out how do we push forward. And so about 30 plus years, we didn't have any breakthroughs for small cell lung cancer until 2018. Where we introduced immunotherapy, which you'll see in my next few slides here, but I just want to sit on this for a second more. There have been so many breakthroughs. This is what we call the second golden age of small cell. There have been a number of therapies that are FDA approved and exciting trials that you guys are seeing in the next few slides come to life that this is no longer the same disease. Patients are living longer. It's a chronic disease now, and hopefully we will be curing more and more patients with the treatment for small cell. So next slide, yeah. So in 2018 and 2019, there were 2 back-to-back studies looking at the role of immunotherapy and how we could potentially help train the immune system to see small cell lung cancer and help build a memory against it so that our immune system could help fight the cancer and help these patients live longer. And so that added about 2 months on average, and this was the first advancement we saw, for lung cancer. Next slide. We just heard this last month at ASCO that now the introduction of immunotherapy earlier in patients who have limited stage, which is localized disease to one section of the chest. Now the immunotherapy has improved survival by 22 months, almost 2 years longer. Patients are living almost 2 years longer because of clinical trials looking at how do we improve outcomes for patients with earlier stage. So if you catch it earlier with screening, you're more likely to be a limited stage, meaning early stage, and then we can add immunotherapy and help patients live almost 2 years longer on average. That means some patients are living even longer than that. This is a breakthrough. This is a game changer. This was just discussed in Chicago earlier this month, and just a complete game changer for small cell. So patients are being, given 22 months, and this is not even mature data. This may continue to be a bigger number than that. Next slide. One of the most exciting things that has happened that led to the accelerated approval by the FDA is the addition of what we call BiTE therapies. I like to think of this as a glue. It's a molecule that brings the immune system closer to the small cell. So there's a marker on the outside of the small cell called DLL3. It's important in the biology and very personalized to small cell. And then there's another bispecific engager with the immune system on what we call CD3. And so it binds to one and the other and forces the immune system to engage and see the small cell and have that, what I call like a little battle there in the lungs or wherever the small cell is. It goes to it and it forces the immune system to see the small cell lung cancer and engage. This has been a complete game changer. When patients have response, which is 40% of the time, the responses are durable, leading to really over a year of responding. Patients are on study and still doing well, still benefiting. Next slide. And what you can see here, this is survival. Patients who are responding to treatment, it's a flat, the curve no longer goes down. This is, patients are living longer. You can see right here on this curve, right, that whenever you respond, it's durable, it's lasting, right? This is so meaningful. This is a complete game changer for patients with small cell. So this drug is called tarlatamab. It was developed by Amgen. And because of that, all the data that was available and so profoundly, remarkably game-changing, the FDA this past month gave an accelerated approval for tarlatamab in patients who have extensive stage small cell and had that prior platinum-based therapy with platinum and etoposide that we talked about. So this is a complete game changer because of clinical trials, because of the research. This is now an opportunity for patients to have hope for long-lasting survival and outcomes to be with their families and live with small cell lung cancer. Next slide. There's a cousin drug to this that is in development, and I'd be remiss to not mention that. There's another drug by Boehringer Ingelheim that is like the little brother tagging along, that is also a very similar drug in this space. It is not yet FDA approved, it's only in clinical trials, and they are also seeing a similar thing. So when we see two of the same things working, we know we're right on target. This is an effective drug, an effective target for small cell lung cancer, and you have two drugs that are showing the same exact thing. With this, patients have to be monitored for infusions because there are potential toxicities that doctors will be watching for because of that little battle in the lungs or wherever that can cause things like fever or low blood pressure or racing heart rate. And so we can help patients through that. It's usually minor, and we can give fluids or medications like Tylenol, but we want to monitor patients for the first treatment or two just to make sure everything's safe before we give it as an outpatient regimen. Next slide. Another exciting role of chemotherapies and medications in small cell lung cancer is something called antibody drug conjugates. These are medications that are like little missiles that can go right to the small cell. So it is an antibody that's unique and goes and finds that small cell. And with that antibody is a little payload or warhead that can go right to the cancer cells and be delivered chemotherapy dropped off right into the cancer cells. So these are pretty cool. They're called antibody drug conjugates, and there's a number of them that are very exciting with response rates up to 60%. 60% of patients who get this therapy have shrinkage of their tumor that's meaningful, right? That you get a scan and things are going, they're shrinking, they're disappearing, right? That's so meaningful, not something new, which is unfortunately has historically been a lot of the treatments with small cell. These are game changers, and I expect these will have some confirmatory studies and hopefully be in the clinics very soon. But the opportunity to get in a clinical trial with medications like this is what we're seeing. They're very exciting. And to the point made earlier with clinical trials and research, the FDA now tightly regulates so much that we have to offer at minimum the therapies and treatment that you would get. It has to be improvement on that. It can't be inferior care. That would be unfair. And that is very tightly monitored and regulated now. Next slide. So I just wanted to take a moment to talk about some of the research we are doing here at Indiana University in my research laboratory that focuses on small cell. So my practice is, I'm a medical oncologist. I have a clinic 1 day a week here at Simon Cancer Center downtown. And then the remaining time, I'm in my laboratory working on novel treatments and therapeutics and how do we make the treatments we have work better. Next slide. This is my laboratory. We are small but mighty. We have four members of the lab. I have a graduate student, a lab technician, a medical resident, and a summer student. And we focus exclusively on research on small cell lung cancer. Next slide. So one of the areas of our focus in the lab is how do we take the treatments we already have and make them work better. Next slide. One of the drugs that was approved by the FDA in 2020 was a drug called lurbinectedin. That's by Jazz Pharmaceuticals. And that was approved by a basket trial showing that patients had a response about 35%, so a little bit lower than what we're seeing with tarlatamab in the 40% range. So about a third of patients respond, and of those patients, a number of them are on treatment for over a year. And so how do we find those patients? How do we find the patients, that needle in the haystack, that will have benefit, that we can improve their quality of life, time with family? How do we keep those patients on treatment longer, get them the right treatment, and really personalize care to them? And so that's what our lab focuses on. This was a chemotherapy that was actually discovered from sea squirts, so a natural product that was brought into the lab and then developed as a cancer therapeutic. Next slide. And so while in my training, we identified about 25 patients who had been treated with this drug since it was approved by the FDA in 2020. And we had a number of patients who did very well on treatment. So we wanted to study their tumor samples and really understand what made them tick compared to patients who were maybe on treatment for 2 or 4 cycles, which is the national average of what we see. So we had patients on treatment for 15, 20, 25 treatments and doing very well and having good scans. So we wanted to know what was unique to their cancer. Next slide. And so we studied their tissue, did proteomics, and did different testing. And we found a biomarker called ISL1, which is unique to small cell. And it's part of the biology that it helps bend the DNA and allow that chemotherapy drug to get in better. So patients who have higher levels are more likely to do really well. And you can see that here on the right. You can see that very dark brown stain compared to the light purple stain. And so patients who have that really intense staining and high levels of this marker are more likely to do well. And so we're moving this forward with some clinical trials to see exactly how these patients do and if that is real, and if we can test that theory back in patients. So this is really what we call a bed to bench side or bench side to bedside approach, where we take patients, learn from them, bring it back to the lab, and then go back to patients and see how we can help improve outcomes. Next slide. Another thing that we're doing at Indiana University Simon Comprehensive Cancer Center is studying every patient who we see with small cell lung cancer. So it's an all-comer study. This is a study I designed and implemented about a year ago. So what it looks like is every patient who comes to our cancer center is approached, consented. We go through what the study would look like, which is 3 tubes of blood, and we follow patients every time they get scans. We can learn from every patient who has small cell, and we want to learn about how the cancer changes over time. There's really not been information we know about kind of the initial disease and biopsies and whenever patients are diagnosed. We just don't know very much about when it comes back and how that's different. And so this is 3 tubes of blood, and we can study the DNA of the cancer, the RNA of the cancer, all the proteins and all the different pieces of what genes are on and off, and how that switches over time with treatment. And so every patient we can learn from, and is a valuable resource, and we can see how their cancer changes over time. Since we launched this about a year ago, we have about 31 patients on study. And so this is a very powerful resource that patients are so kind to participate and to let us study. their cancers and understand exactly how it changes over time so that that can help that patient, but also help someone else in the future. So next slide. So this is a patient of mine who initially presented, was short of breath, had an imaging scan that found he had a very large left lung mass. He had involvement in the lining of the lung as well, which he was having a lot of pain, which is what brought him to the hospital. And he was underwent a bronchoscopy with a biopsy and was ultimately diagnosed with small cell. We treated him. You can see this is the very first one on the left is his original at baseline. These are circulating tumor cells. These are tumor cells in the bloodstream. As mentioned, this cancer likes to spread, and so we can capture those cells and study them. And so you can see as he got initial treatment, that first red arrow, the numbers dropped, almost thousands of folds down. But as we did treatment, the cancer came back, and you can see those numbers going back up. And so what changed? What was the difference in those cells? The treatment remained the same, the patient remained the same, but how did the biology change? And so that's what our lab studies. He switched to another treatment. You can see it was effective. He had dropping of the counts, but then again, it came right back up. And why? What changed? And so that's what we can study, and we can learn from every patient, whether that's a medication that they're getting or just being kind and donating back to their community and their maybe a patient in the future that we can learn from and help make differences for. And so we study how this cancer changes, and we hope that we can offer effective therapies the first time around. But if not, how can we learn from it and change and be effective the second time around? And so I think these BITE therapies are really going to be a game changer for patients. We know that they're living longer, they're having more time with their family, and having good quality of life, which is the whole reason we're doing all of this. It's about family, it's about that fellowship, and making the moments that bring patients joy happen more and more and more. So next slide. I think we are entering a new era for small cell. The whole point of today is to show the hope, the excitement, the clarity that we are seeing with small cell and breakthroughs. We know that there's effective treatments such as the one we talked about with lurbinectedin, and that maybe we can find those responders by a certain test. We know that these medications with the DLL3 BITEs, as such as Amgen and Boehringer Ingelheim, also have. Amgen's was recently FDA approved, so that means it could be given across the country. These are huge breakthroughs, and so how can we learn from these tumors and be on that game of chess in the next move and the next move? And how do we find these new targets that we need? So I think breakthrough is on the horizon, and I would say victory is already here. So next slide. And lastly, how do we end lung cancer now for small cell lung cancer? End Lung Cancer Now is an initiative that is at Indiana University Simon Comprehensive Cancer Center to help raise awareness, research, screening, and build a community for for lung cancer. And so we wanted to focus on small cell. And so how do we build a voice for small cell lung cancer? Next slide. One way we can do that is to have a voice, a patient advocacy group for patients and families and caregivers who may be afflicted or may previously been diagnosed with small cell lung cancer. And so with a partnership with Longevity Foundation, we launched the Small Cell Smashers patient advocacy group. We have a Twitter handle, we have a Facebook group. We have almost about 400 patients and their families and caregivers on there to provide information that's much better than Dr. Google and would not be effective or kind and does not have a good bedside manner. But to help spread hope, to end stigma, to raise awareness, to build a community, and to put the power back into the patient's hands. It's your voice, it's your advocacy for change that will bring the next wave of victories. And I think that victory is already here, but we have to work together to really bind our voices together to raise awareness for lung cancer and for small cell lung cancer. So I encourage you, join our group. We want to hear your voices and in this fight together against small cell. Next slide. So thank you all for your time, and I will pass the mic back over to you all.
Thank you very
all.
much. And I want to remind everyone that both online and here, we'll have time for questions in just a very few minutes. Just out of curiosity, show of hands, if anyone here is going to someplace that is new to them, what tools do you use to get there on time? Some things you might use. Anybody? Map? What else? GPS. All right. So we recognize that when we're going through a new experience to get to someplace, we don't necessarily just get in the car or whatever or start walking. We have something that kind of guides us along. Just trying to find out. And again, I'm not, unlike Dr. Kane, I'm not going to pick on men to say that we naturally know where we're going and won't ask for directions. But I think this is universal, to be tell you the truth. Our next speaker is Ms. Sherry McKinney. You always get it right on the second try. Okay, I'm still standing. Our next speaker is Ms. Sherry McKinney. Ms. McKinney is a graduate of both the Jewish Hospital College of Nursing and Allied Health at the Barnes Jewish Hospital in St. Louis and the Western Governors University of Indiana School of Health and Nursing. She is currently lung cancer screening nurse navigator, and you see why I asked that question, oncology nurse navigator at Indiana University Health Simon Cancer Pavilion. Ms. McKinney will address the very important topic of cancer patient navigation, care, and support. Ms. McKinney, thank you very much. You want here or do you want to walk around? Monsieur? Okay. Yes, ma'am.
Well, thank you, everyone. What a great opportunity this is. Thank you very much. Navigation, you know, when I learned about navigation, I had been an oncology nurse I started very young. At 40, I've been a nurse for 40 years working with oncology. And when I learned about navigation and what it does, I thought, oh my goodness, what a great opportunity for me to do what I think I'm called to do. And it's something that I've done for my friends and my family for many years. Oncology care is complicated. You know, there are so many things, resources available to people. How in the world, Ms. Ford talked about, you know, earlier, it's overwhelming. The diagnosis itself is overwhelming. And then all these wonderful resources available, how do I access them? How do I even know they're out there? So that's what navigation is. It is taking all these resources available and bringing them to the person when they need them the most, right? Even if you deal with oncology for a living, when you get that diagnosis yourself, it's overwhelming, you know, having someone to walk through this journey with you. That's what this is about, right? So how blessed am I to be able to do that? Because I think it's so valuable. So that's what navigation is. And we want you to know that that person is there. It's available, it's free of charge. There's no additional charge for that. We meet the people at the time of their diagnosis. And everybody is different at that time. You know, some people come to us with this unbelievable wealth of knowledge already, right? And what they need is help to put it all together and how to find the right doctor. We have so many fabulous resources. But finding the right person for the patient at the right time, you know. We see oftentimes people had been waiting for weeks for a doctor's appointment, and they get to the doctor's appointment and it's not even the right doctor. They're at a radiation oncologist and they need to be at a surgeon, or they're at, you know, that's wasted time. Nobody wants to waste time under any circumstances, but especially with a diagnosis of cancer, you don't want to waste time. So that's important, right? To be at the right place at the right time. So that's something that a navigator does. Just meeting the people and finding out what you need. You might need that information. Maybe you've been to a bad place to get information. On the internet is a wealth of wonderful information, but sometimes it's not all accurate, right? So making sure that you have the right information, you know, is so key. Because we've already talked about this with this wonderful HEAL initiative. You're empowered with education. So we want to empower you with that education if that's what you want. Some people just want to know, what's that next thing that I don't really want to hear the rest of it. I just want to know, how do I get to this one place? All right, that's what we're here for. We're going to help you get to that next place. Some people want to know 100 steps ahead. What am I going to go through? What are my options? Okay, that's what we're going to do too. Everyone is different, and we want to meet you where you are and get you to where you need to be next. So that's what the role of a navigator is. I would be amiss to not again bring up the importance of screening. Screening saves lives. If you can find out earlier, you find out, the better you'll be. It's amazing the advancements. I've been a nurse for 40 years, and about 6 years ago, I started into this navigation piece, working on that. And the changes in lung cancer treatment from when I first started, in oncology even, to now is unbelievable. So that's another thing with navigation that I think is important, is understanding where the person has been before and their previous experience with cancer and even lung cancer. Because if you've experienced lung cancer 10 years ago, even as little as 10 years ago, or 20 or 30 years ago with your parents or your grandparents, it's a different world now, you know. How we manage symptoms, people do much better with treatment now. And how we treat them all through and how they tolerate the treatment, it's all quite different. So even some people are like, I don't even want to know if I have cancer because my grandpa had it and he went through a really terrible, difficult situation and it was terrible. And it's not an easy thing to get, but we can help you, and we are doing much better with helping you get through it and get through it better. So quality of life is better, but still, no matter what stage you get diagnosed, but you're always better when you get diagnosed early. So screening saves lives. If you're questioning whether you might be eligible or you know someone who might be eligible, if you want to talk through that, our information is there. I'm here. I'm more than happy to talk with anyone who thinks that they might be eligible. The great news, I think, about screening here, with screening is paid for at 100% if you have any kind of insurance coverage at all, Medicare, Medicaid, any kind of insurance coverage, no out-of-pocket costs. If you meet the eligibility criteria that we talked about, there is no cost to you. It takes 10 minutes. A CT scan is painless. There's no IVs, there's no needles, there's no prep, there's no squeezing, prodding, nothing like that. You're in and out in 10 minutes. And you do that one time a year, and it saves lives. So that covers navigation and covers screening. So thank you very much for the.
Thank you. Thank you. Thank you. Ms. McKinney, just like the rest of our speakers, will be available for our question and answer session. And probably you know Ms. McKinney. I don't know if Dr. Kane also, I'm sure, knows that the Nurse Navigator program was born out of Harlem Hospital with the most illustrious Dr. Harold Freeman, who Dr. Kane, you may not know, is a Howard person, by the way. But the main thing is that he was Howard. That's what I should understand. Howard. That's what I want. That was the key point there. That's no problem. The Howard tent is grand. Our next speaker is Dr. Naomi Doe. Dr. Doe received her bachelor's degree in physiology from the University of Minnesota, which is famous for its rodent mascot. She then attended and received her doctorate of pharmacy degree from the University of Wisconsin School of Pharmacy, where the mascot is a wolverine. And Dr. Doe, when you get right down to it, that's nothing but a buffed up weasel. She has a history in Indiana, and as the song says, she is now back home again in Indiana, and where the real mascots live, being a Hoosier. Dr. Doe is now the Associate Medical Scientific Director of Early Development Oncology, Amgen. She has come here today to tell us a bit about what Amgen is doing in the non-small cell lung cancer space, and small cell lung cancer space rather, and finally, be associated with the proper mascot again, the Hoosier. Welcome back. You want here or you want to walk around? Yes, ma'am.
All right. Thank you, everyone. Good morning, good afternoon. It is such a pleasure to be here today. So my name is Naomi Doe, and I'm representing Amgen. So, some of you might have asked, what is Amgen, right? We are a biotechnology company. We're dedicated to work on finding new treatment for diseases. And like you've heard today, a lot of it is cancer. So lung cancer, small cell lung cancer, non-small cell lung cancer. And I guess a big reason why I'm here today is really to talk about inclusivity in clinical trial. So what is a clinical trial, right? So before these drugs get into the market and be available for everybody, we need to do a bunch of testing. And so a doctor will give this new medication to the population, to patient, and to see if they're working, if they're effective, if they're safe. And so in order for us to prove that it is safe for everyone and that it is effective for everyone, we need a very inclusive population. And so when talk about clinical trial, there is population where they're not as represented, and we want to make sure that everybody know what a clinical trial is, what are we currently testing, and how we can be all inclusive to ensure that the medication work for everybody, despite their age or their race or where they come from, their ethnicity, their gender. So currently Amgen has 2 clinical trials in small cell lung cancer that is here in Indianapolis. One is in limited stage and one is in extensive stage. And we'll be available later on at the booth outside, so we can talk more, but I'm happy to walk you through. I understand sometimes clinical trial can be intimidating because you don't know what you're getting yourself into, so that's why we're here to help. And I really encourage you to really think about or take a look into clinical trial or know somebody that you can talk to or prefer to us to talk about clinical trial, because we really need that representation. We really want to understand how the drug work on everybody. And so that's why I'm here today. I'd be happy to chat more with you outside, but yeah, really nice to meet everyone.
Well, don't go anywhere, just stay here for the panel. You don't get to leave. You get to be the first one sitting down.
Oh, okay.
Let's bring our speakers back up. Ms. McKinney, Dr. Shields, the great Dr. Fleming. Oh, no paper. I've heard that said. If you have a question, raise your hand and we'll bring a microphone to you. Also, if you're online, send it in to us. So yeah, one of the first questions that we received online was, is lung cancer hereditary? Dr. Fleming, would you? That was you? I'm sorry. We have a person right in front of us who asked that question. Okay.
Turn them on.
Yeah, so there are some links that have been shown that there's a genetic link to developing lung cancer. I know in African Americans there's specific genes of JAK that have been recognized that there is a link that have you at an increased risk or likelihood of developing lung cancer despite smoking. And in other populations, there's some link with genetics. I think with the Asian populations, we know that non-smoking agents is more like a specific biomarker testing that can target treatment towards. So yes, there is a link, especially a strong family history of lung cancer, that a large percentage of them were not smokers, that they may be more susceptible to develop lung cancer.
Yeah, absolutely. So definitely there are some genetic genes you're born with, you inherit from mom and dad, components to lung cancer. It's not as often as mentioned, but it is important if you have a family history of lung cancer to let your doctor know about that. Yeah, can you? Oh, I get what I hear. So if you have a family history of lung cancer, definitely let your doctors know so that the right testing, whether that's even genetic counseling, can be.
Start using this one.
Try it. I can try it. Go ahead. Yeah.
Okay. You can hear me over there? Okay, very good. Okay. So definitely talk to your doctor, let them know, or if it's a loved one, let them know you have a family history of lung cancer.
There are also other complexities to it that, there was a recent study out of Taiwan that women who had a family history of lung cancer but were never smokers were actually at higher risk than patients who were males who had a history of lung cancer and smoking. And so there's been some other studies as to air pollution, if that's contributing, and there is data out of the UK by the Swanton Group and research in the UK to show that air pollution also is another leading cause. We see that more with non-small cell lung cancer, but small cell can arise from non-small cell lung cancer. So it's very complicated. That's something called transformed small cell that can arise from EGFR or ALK non-small cell. So these are all important pieces that you should definitely let your doctor or your family let them know because it can be important, another piece of the puzzle.
Hold on, we'll come to you in a moment. Let him finish that.
I want to add let me add something to that.
This was the one.
We just started screening. If you look in comparison of prostate and colon cancer and breast cancer, lung cancer screening is pretty new. But what we started to do is we start identifying patients because they're getting screening. We catch it when it's earlier. It gives us more information about these. So we're starting to learn things. This is new in the process. And having more African Americans in some of these studies, it doesn't always have to be treatment. It could be, just looking for risk factors, right? And that'll tell us, and we'll start to learn more exactly how strong this genetic link is as we start participating more in encouraging people that have these cancers to identify themselves so we can find out that.
Would you also comment, though, when we talk about environmental pollutants, one of the big problems in African American neighborhoods and a lot of lower socioeconomic groups, you have the particulate matter, and that seems to be having a really significant problem, especially brought up by when COVID was around. So how does that factor in? Is it a multiplier or is it independent determinant as far as people with lung cancer?
It's both an independent and it is a multiplier when it's linked with other. And if you think about the neighborhoods and communities where African Americans live, near the landfills, near a lot of the factories, because it's closer to work, right? All those factors do play a role and does increase it, and it is a multiplier.
Dr. Kane, you had a comment.
Yes, we do housing inspections, so houses that have radon is a major contributor to lung cancer. So people should really get your houses or apartments to be inspected. But think about it. If you're living out in the suburbs, there are very few chemical companies out there. You see less lung cancer. But for us, we're more likely to be in the inner city with a lot of chemicals surrounding us for air pollution and everything. Is so we almost like a double win in terms of our increase for lung cancer among our population.
Okay. We have a question right here. Yes, sir.
My question is that once that small cell develops and you're a smoker, now you continue to smoke, it makes it work, right? But if you stop smoking, is that reversible?
Yeah, absolutely. So I'll explain it usually to my patients. We have this conversation because you're putting in all of this effort to come to treatments, to get infusions, to get radiation, to get chemo, to get immunotherapy. There's so much investment from the patient and their families and caregivers that you don't want to reverse all of those positive effects you're having. It's like continuing to feed the cancer with that nicotine. And we know that patients who have small cell are at higher risk for a second, even lung cancer in 2 years. Even if you do everything right on treating the first one, that there's a risk if you keep smoking because it's just continuing to, it's like having your foot on the gas and the brake at the same time, driving a car. And so, we do know that it can negate or decrease the positive effects of what you're doing and your investment of all your time and your money and side effects and all those things of being treated. So I tell my patients, even if it's one less cigarette a day, it's the progress. It's not perfection. It's one step at a time, and it's working towards that goal. And there's resources to help with we have experts who can help with giving medications or patches or lozenges or medications to help cut down the nicotine addictive effects that were designed, that were targeted, to make us want to, smoke more.
Yeah.
And so we can help support with that. And there's resources available. There's hotlines that are available as well. I think you could probably speak to that more than me, Sherry.
And we did bring some information in the back about that. That 1-800-QUIT-NOW is an initiative that there is no cost to you for that. They do have some opportunity for patches and lozenges and gum and those things that are no charge as well, a couple weeks worth. There's lots of support out there to help you quit.
Thank you. You have a question here.
I could see more deeply that, but you were talking about the neighborhood. If you have been exposed to asbestos, and you never smoked, and years ago, and then maybe 10, 20 years later, you developed a palate body. Having started, is it possible that it's by having effects the negative asbestos in years ago and developed problems?
Yes,
Is
yes.
that possible?
So asbestos was, it's great as an insulation. It's great. It's terrible for the body because it's a little tiny fiber that your body can't break down.
Okay.
And so, and they just get into the lungs, and what can happen there is, even if it doesn't cause one of the two cancers it's linked to, either lung or mesothelioma, it can scar the lungs better. So if you know you had that exposure, yeah, then you when you speak or meet with your primary care doctor, you alert them to that, so that they have all the information to start saying what needs to be done, how do we check this, see if any of your symptoms are related to it or not.
Do you think that should be part, we all do something called a review of systems when you ask people about family history, where, all this stuff. Do you think we need to start asking, where do you live as part of our review of systems to really determine the risk for somebody?
I think absolutely. I ask, where do you live? What part of the city do you live in? What type of work do you do? What type of work did you used to do? Right. Because all those play a role into what the risk are.
It used to be, what the guy said, it was, you're a zip code should not have more determinant on your health than your genetic code. Basically.
Yeah, I know Dr. Hannah, who is the lead of our inland cancer now, says your zip code should not be your destiny.
Exactly.
Right, and so that's what we're here to support, is to make sure everybody gets the same care and individualized care. And so I agree, as a physician, you should also be asking about other exposures, other chemicals, anything that in the home, outside of the home, that we should do better of asking those questions.
I know we have many questions, but I want to take advantage of two particular people. Since we have a state representative and we have the public health director here. So the question is, and perhaps you all may want to chime in, what impact, I know in Kentucky we patted ourselves on the back and we're very happy that we raised the cost of a pack of cigarettes by 50%. We still have the cheapest cigarettes around except for Virginia. But Representative Porter, what impact does raising the cost on a pack of cigarettes have, and how effective is that as far as decreasing people smoking and perhaps even lung cancer?
Well, here, when we've had that discussion here in the state on numerous occasions, we've talked about trying to raise $1 a pack or even $2 a pack. But we have to understand that Indiana, a lot of us are rural community. Even if we shoot for $1 or $2 a pack, we really want $1 a pack. And I don't think we've raised pack insurance, tax on insurance for that probably about 5 to 6 years, maybe not longer. But we also understand that when we raise the price of cigarettes, is that people do stop smoking. And well, I think for us, other than you guys in Kentucky, I think we've had the lowest rate of taxes on cigarettes. Because I know people come in from Illinois, other places that die in the border counties that die cigarettes.
How would you comment?
I think it's so important to try to raise the cigarette taxes because it prevents someone from being a new smoker, especially our teenagers and their young 20s. So that raising that tax is huge difference. Florida is very successful when they raise their taxes for getting new smokers. So that's the place to be.
And I would just add to that, we do know that e-cigarettes are also an increased risk of lung cancer. And so just switching from one to another is not, I see so many young people that
or doing the, I guess e-cigarettes and vaping, that is not without line. And so that's not a great alternative to switch to.
Yeah, and I know specifically for Indiana, so right now for a pack of cigarettes, the tax is like 99 cents, and it has been proposed, and I think they're looking at $5, like you're saying, they're raising for $5. But the other thing I think that a lot of the states need to look at is where does that actual money go towards, where the revenue comes from. I think here in Indiana, you're getting about $500 million a year off of the tax tobacco revenue, but a very small percentage of it actually goes towards the cessation program. I think they're only paying like $9 million a year for stopping smoking and prevention. So a large percentage of it goes to other processes, housing and city initiatives, but a focus on the health-related aspects of tobacco smoking and maybe moving that money in that direction would help involvement.
We have a question over here.
Yeah. Studying age belonging say it's 50 to 80. And this is also the age what the society medically pays its attention to. So how do we encourage our health providers to take the life of this age group seriously?
That's the kind of question you get from an HBCU graduate. Which one of y'all would like to take that?
So you say one. So you're saying that the age I know is 50 to 80, and you're saying that's the group that's least likely to have. One way to be advocates for ourselves, right? And we have to go out and bring it to a point. If we're not paying attention to it as healthcare providers, then it's good to bring it to our attention. A lot of times we get so caught up in so many other things, but we start being advocates for ourselves. The other thing is we're focusing now into the medical education to move us in that direction.
Yes, and I say that because I've been to doctor's appointments with my mother.
Is 80 next, even discussing how she's treated when she goes by herself versus when someone goes with her. Because she's actually had doctors say stuff like, oh, well, that's your age, and that type of thing. But she's a real advocate for health, and so just wanted to
Get your response on that.
I might add, one of the things you may want to make sure of is she's seeing a geriatric physician. A whole different ballgame compared to, not saying anything bad about primary care docs, but the geriatric physician tends to have a different perspective on how to take care of that patient. So you'll find oftentimes the first thing they do is cut the medications that the patient is on, and that improves health.
And I think also to that point, I agree. I think a geriatrician they are absolutely wonderful, and they tailor it and also can help to de-prescribe the medications that are not helpful in another pill and another burden on a patient to take that, may not be appropriate or may cause harmful side effects, in older patients. But I think we also have to be better from a systems standpoint. Our medical electronic records have to trigger and let us know, hey, this is a patient, right? We have to have those fail-safes in place, from the primary care and the health system standpoint, and in the records that, that's triggered, and there's an objective reminder that patients should be screened, and hey, they're due for their next screening, and they're due for their next screening. There has to be support in place by the health systems too, so that this is all, maintained and tracked.
Yeah.
All right. You want to say something? You did not talk about surgery when you gave your talk. I mean, and as a surgeon, I'm not offended, but I was shocked. But someone has come to my rescue. What is your question, please?
It's not necessarily a question, it's a place report. I approached my doctor February of 23 to test me for lung cancer. Long story short, 1 year exactly, after 4 scans. She wanted to do surgery ASAP, but I had another commitment, so that March 26th of this year, I was diagnosed with stage 1 lung cancer. They got it on, no chemo, no radiation, and I'm so grateful. I have to thank God, but I cannot not thank God.
So the question then becomes, is there a role for surgery, and when do you consider surgery?
Yeah, so screening saves lives.
Screening saves lives.
I was never sick.
Yes.
I'm still not sick.
Yes.
I'm on
Yep.
recovery.
Yes, this is absolutely, these are the testimonies, the breakthroughs. This is the face of screening, right? These are the lives that are saved. It's so important. So small cell, about 5% or less is treated with surgery, followed typically by 4 rounds of chemotherapy. I will say that as we are doing more screening at IU, I'm seeing more limited stage than I've ever seen, which is great. It's catching it earlier, and I have patients who go to surgery and it's instantly found to be small cell because it was just a little ditzel on a scan that was, let's go ahead, instead of the biopsy, let's go to surgery and we'll cut it out and figure it out, and it happened to be small cell, and I'm seeing more and more of these. So I think surgery would play more of a role. And the best thing we can do for cancer is cut it out, right? Surgery is curative intent. And then with small cell, we like to do a couple rounds of chemo afterwards just to make sure there's no potential circulating cancer cells that are hiding somewhere to reduce that risk of it coming back. So, but again, congratulations.
Before we come to the next question, Dr. Doe, tell us a little bit. You mentioned about clinical trials, we've heard of it. What are the phases and what are the, we all know, again, the bad stuff. So what are the guardrails when we're talking about clinical trials, please?
Yeah, so I think a clinical trial is like a staircase. There's multiple phases, and the most common one that everyone knows is phase 1, 2, and 3. That's because it's before FDA approval of a drug. So what a phase 1 is it's really testing the safety of the drug. So that at phase 1, we're looking for what dose is efficacious, as well as is it safe to administer to either healthy or patients with or oncology trial with cancer. And phase 2 and 3, I think of it as like phase 1 on steroids. There's just more patients, there's more specific, and really testing, again, safety and efficacy. Once we're proven that it is safe and efficacious, then able to file to a regulatory body, like in the US would be the FDA, will get what it calls an approval. And so for, that this the small cell lung cancer treatment that all the doctors mentioned earlier, tarlatamab, has actually gone on accelerated approval for small cell lung cancer, which is a great breakthrough for a condition that we didn't really have a lot of treatment in the recent. So those are the 3 phases. And then because the treatment continue to be administered to the public in the long term, we'll do what's called phase 4, which means these are analysis that we do in a drug that was already in the market to really monitor how is that an impact on a larger population. So more patients come on. It's not just in trials, now in the public for use, right? And so my role at Amgen is medical monitor, and what we do is basically we really closely monitor every subject that goes through a clinical trial, and we make sure that they're safe, the drug is efficacious, that it showed benefit to the subject, and making sure that doctors or clinician at clinic is really following through with the patients and making sure that everything is on track. So we're that second guardrail to your doctor that are meeting you, every week or every month to make sure to monitor your progress on the clinical trial. Okay. It doesn't like me. All right, so I hope that answered the question. And there, again, in the recent new medicine, there has been a lot of guardrail that put in place by regulatory agency to ensure that testing is safe on the subject. And like I was alluded to earlier, we want to make sure that we have a very inclusive population when we're testing. We want to make sure that our drug work on everybody despite their race, their age, or their gender, or where they live, right? And your participation in clinical trial really is going to not only find a cure or a treatment for the disease, but also it's a stand for your community and how you can prove that, okay, this drug is also working for me.
Thank you very much. Yes, sir.
So my brothers and I grew up in a secondhand smoking home. And fast forward to 20, I was sick all the time. I think the doctors knew that when you're exposed, if you're secondhand smoking,
They get sick too.
so fast forward 2022, my oldest brother was diagnosed with pulmonary fibrosis. So my question is, the relationship between the secondhand smoke and the small cell lung cancer.
And please define what primary, secondary, and tertiary smoking is.
Yeah, so primary, you're the smoker. Secondhand smoking, you're getting the smoke that cook in and breathe out and whatever else. And then tertiary is just kind of an environment that kids caught on carpet and stuff like that. So yes, yes, and yes. Okay. So there is an increased risk. When we think about cancer and smoking, and definitely there's a, but anything burned and inhaled into the lungs is going to cause some sort of damage. There's scarring of fibrosis. There's long names to this, but yeah, it scars up the lungs, it injures the lungs, you get inflammation. Kids are more susceptible to getting infection. Sinus infections, ear infections, and asthma has been linked to being secondhand smoke. So all of these things do play a role, and it just depends on the amount of exposure you do it. Now, we do know that people who have been exposed to secondhand smoke do have a higher risk of developing lung cancer. It's just hard to really quantitate, like how, you can't tell them how much secondhand smoke they're getting from the family members and stuff like that. But there are risks, there are health risks to those people that are smoking around, or they have people smoking around them, all the way from the youngest to the oldest.
We have a question back here. Go ahead, man.
Okay, so.
Put your mask down because it's kind of hard to hear. I'll step away from you. I'll hold it.
So basically, my question is like his question. My mom was a heavy smoker. You could see it. She had 5 kids, and none of us. Do that. So I wanted to ask the same thing. Could you speak about the occurrence of lung cancer and secondhand smoke? And have there been any clinical trials on the incidence of cancer, and how do we reduce those? Looking at the numbers and everything that you shared, I did not see anything saying that people who have been exposed to secondhand smoke should get looked at and explained. So how does that work?
Let me ask you a question before you go. Describe the neighborhood in which you grew up in.
I grew up in Georgia.
Georgia.
I'm from Macon, Georgia. And we were in a mixed neighborhood.
In terms of industry.
Industry, there was no industry in that.
So I guess really the crux of this question comes down to, how do we account for people exposed to secondhand smoke? And also, she was coming out of Macon, Georgia, an area I believe that's going to be high in radon. So how do we take that into account? And then if I may add, in some neighborhoods you're going to have a high risk of exposure to industrial pollutants, which can also, as you talked about earlier. So are we missing the boat as far as screening, and how set is the United States Public Health, the Public Service, Preventative Service Task Force on setting up our guidelines?
So because it's really hard to quantitate how much secondhand smoke you have to be exposed to develop lung cancer, it's just hard that they haven't come out with a recommendation. We do recognize that exposure to secondhand smoke will increase your risk of developing lung cancer. But it's hard to say, well, if your loved one or the person you're exposed to smoke half a pack a day, but we can't quantitate it to give a hard recommendation. So that's where it's very important to have those discussions with your primary care doctor so they can start putting all this together. And then the radon part, it's real. In Georgia, it's real, but not a lot of people know about it. Not a lot of people in neighborhoods where, the person down the street had cancer, and this person over here had cancer in the neighborhood. Your neighborhood may be what's impacted. And in Indiana, it's extremely real. Like I said, of the people that submitted the radon test, 40% of them had levels detected in their houses that were above the EPA's recommendations for safety, which tells you a lot more people need to be tested.
Just to add to are we screening the right patients, right? And I know out of Mississippi, Dr. Ray had a wonderful study that was published just recently showing that patients who went to the ER for some other reason to the emergency room happened to get, ER physicians like to do a lot of CT scans,
rightfully so, to rule out anything that could be very harmful immediately to us. That those patients who were identified in the ER to have a lung nodule but no risk factors that would make them eligible for screening, there's still a very high risk for developing a lung cancer, and those patients should be captured and screened too. So we're obligated to follow anybody with lung nodules to make sure they either go away or that they're followed and either biopsied or appropriately managed. And so we do have a study that we're developing at Indiana University to look to push the limits on the risk factors, right? What other occupations put you at risk, what other environmental or family or pollutions. So we do have a study that's up and coming for pushing those boundaries on screening, and are we screening the right patients. So I think there'll be more to come, but that's definitely a conversation to have with your doctor about if that's right for you, based on your family history and your environmental history.
Ms. McKinney, we've heard a little bit about going online to get information. How do we determine what's a good source?
That's a great question. And it is so difficult to stay at the right sources. You know, I'm very educated in lung cancer, and I'll get online and then you'll see something and you'll click some information or a link, and all of a sudden you started at a good site and you're at a bad site. and it looks good though, you know, just like anything else with technology, we can be fooled very quickly into being at the wrong site. So we provide lots of education about that. At the university we do, at the Simon Cancer Center we do, that provides lists of good sites where you can access information that is accurate. If I might just stop back to the other screening opportunity, 50% of the people right now diagnosed with lung cancer did not meet the screening criteria. So that's scary. So we're missing a lot of people, the people like you're talking about. But 5% of the people that do meet the screening criteria are getting screened. So we can do better. We can do better with that, but there is so much, and we are lobbying to increase education to the primary care physicians, emergency room physicians, the public, to try to get this information out to you, to try to get this information out so that we can save lives. Yeah. But we need help with that too. We need your voices. Go ahead,
The
Dr.
U.S.
King.
Preventive Task Force has in the past responded to medical societies and also patient groups. Look at colorectal cancer going down from 50 to 45. And I think even made the adjustment as far as lung cancer screening. Too.
Yeah,
If you wish, sir.
I come. Yes, actually, so in 2019, there were 3 studies that came out. So what was happening is the original criteria, the age limit was higher. And one of the studies we actually published out of where we are there in Atlanta, I diagnosed about 180 new cases with lung cancer a year. About 95% of those patients are African American. And what I found is I had very young people, 34, 29, 27-year-old with stage 4 lung cancer, and I put those together. We went back and looked at all the people we diagnosed with lung cancer. We knew they had it, not 95% African American. And we looked at their ages, and we found about 11% were underneath the criteria for screening. That means they never had a chance. 6% were above it. That's 17%. 1 out of every 6 African American patients that had lung cancer didn't meet the criteria, and we published it. 2 other studies published looking at smoking, that I talked about the rates, smoke equal but have more lung cancer, and that's when the criteria changed. So the more we get ourselves screened and we learn about early lung cancer, especially African American, that data gets incorporated so that this one size of screening can be adjusted, so now we get focused like a student.
I know we have had so many good questions, but this is going to have to be the last one. I encourage everyone, if you have other questions, the panel members will be around. There's a lunch. Representatives from Amgen will be around. Bug the devil out of them. Bug the devil. I'm coming.
When do I eat?
You don't get to eat. They have a blueberry set aside for you, sir. And then for the rest of the panel, they'll be around. So, the Lena Horne look-alike. Go ahead, ma'am, please.
Hi, I was diagnosed back in 2020 with non-small cell cancer stage 1. And my question is, I've never been a smoker, so there's been nothing missing like in my doctors whether or not my children should be screened up their screen, because I guess I did not need any criteria. Was there suggestion that my children have to be pre-screened for the lung cancer? Is there a certain age that you need to be screened by?
Should never smoke.
Yeah, I think that's definitely a personalized decision between you and your doctor, I would say, because there's not really guidelines yet. As mentioned earlier, there was a wonderful study out of Taiwan and females who were never smokers diagnosed with lung cancer, and the role of continuing to screen family members of next generations. So a grandmother and then a mother and all of her children, and those patients, those family members benefited from screening. And that was in Taiwan. So I don't know, if we don't have that data yet in the U.S. and our patient demographics and population and all the risk factors that are unique to the Western world. But I think that's definitely a conversation to have. I think, there is likely a higher risk given that, you have never smoked. There's clearly a genetic component of some sort, whether that's just the cancer cell having a new genetic component or that's something you were potentially born with and may have passed on. It's just hard to know. I don't know if we have enough data to support it, but it's definitely a conversation you should have. So you have, peace of mind, and also have your family have peace of mind, and whether, considering genetic counseling and all of those other pieces to dig further, definitely get those questions answered.
Yeah, but I think it's something you definitely earmark, right? Because if let's get out of this and go to what we've learned about breast cancer. Your mother had it or your sister had it, whatever else, it's marked and it's checked and whatever. Now, when exactly did it get screened? All that information hasn't come back, but it's something to keep if you have a strong family list, right, of somebody who was a never smoker that had lung cancer, and they need to keep that in mind and pass that on at any time they're being seen with their primary care.
Well, I think we ought to give a hand to our panel. I think they did a great job. Thank you. I want to remind you, both those here in the sanctuary and those who are online watching, please fill out the post now. You can do the pre again if you didn't finish it, but now you can do the post evaluation. And it has a little barcode if you want. You can scan that and fill it out that way. Again, I'm technically challenged, and if you're like me, then just fill out the paper and do it on hand. Remind you again that there will be lunch, and the representatives from Amgen, as well as our panel members, will be available for those of you who may have had some questions or want a little more in depth. I do want to give a particular say, Gabriel, I think you all would be very happy. Pastor Lester, I applaud you. We had one lady who was watching online and came in because she wanted to So clearly, we're doing something right. At this point, I would like to turn things back over to Pastor Lester to take us out, and I will remind all of you, he is the one thing that is standing between us and lunch. However, Pastor left. Oh, Lord. I'm in trouble. Y'all set me up with a ringer, man. You didn't even tell me, Representative. Come on. I'll let you take us out, please, man. Thank you very much.
Thank you so much. Thank you. I am glad you get it. I'd like to have Pastor Lester step out. We do want to thank our panel at the end for a wonderful job. You know, he did it and you excellent job. Thank you so much.
Thank you.
Thank you so much. And the questions, I tell you, I learned so much. That's what God is doing in our lives. I had to get good listening. And as soon as I got in, I took that money because I didn't hear the information that I did not know. And I thought I had to be it. So I'm so good at information that I learned that I did not know. In the bank, Dr. Katie, to be here, y'all dance. And he did me to thank that. I don't know that any doctor for it. Only thing, stupid things that they're announced. Okay? You know, they thought, and hear it for making these possible. So at this time, we not go out where we just sing and get in that in that years, especially everybody. Thank you for this. Like Samson, like dentist. Wow. If I need to, he does how he keep the big hand. If I need to, he does. Everything's had him thinking. What I need to do is, he's a arrogant. He had West OT. He had one home. Like Daddy just asked that you be able to understand. I'm studying on cancer. You're going to ask that you continue to get that and that you continue to get knowledge and wisdom to development. Wrong to know. So that we ask that you bless the thing. Yes, it's some hands that the kid. And the mighty name of Jesus be falling. Yeah, all those that did it in our school say amen.
Amen.
Thank you. Great job.
Oh, thank you.
Great job. Thank you. So Chill's great. Thank you very much for being here today. Ms. McKay, thank you. You did a wonderful job. I haven't met a navigator yet that I didn't like. Y'all great, man. It's a great group of people, man. Great. Thank you. Outstanding job as always. I really like you getting out there roaming around, man. Do I still have a microphone on?
Oh, thank you. Pleasure. So, yeah, I finished a long time ago. Something like that. Small world.
I know. Crazy place that keeps growing and growing.
I don't know what I did with the damn thing. Uh-oh, I broke it. Something came off.
It only costs money.
What's that, man? Not mine. I didn't need it, man. Where'd it go? Huh. That's weird, man. It's the clip part, isn't it? Oh, it's the whole thing. I'll take this off then. I don't know. I owe him a thing. Thank you. Oh, I mean, I forgot to thank you guys. I had it down there. Thank you very much, sir. You're welcome. Thank you. Thank you. Good job. I don't know where this thing is, man. Not there. It's not on there.
It didn't drop into a pocket.
Ah, here it is.
Oh, yeah. Okay.
I was getting nervous there for a minute. Take it up to him. Hey, I don't know what I did with the, did I miss the piece?
It may have fallen off in your shirt.
I looked, yeah.
Or fallen down somewhere. It happens, it falls down, and because you were mostly over there, right?
Yeah.
I'll look for it over there.
Okay, so, and when I pull things off, that...